Hello, PsyQ community. Welcome to today's webinar, The Effect of a National Pandemic on a Patient with Bipolar Disorder. Thank you for joining us today. I am Dr. Dri Wang. I'm a Senior Medical Science Liaison for Otsuka Pharmaceutical Development and Commercialization. I'll be serving as moderator and presenter for today's exciting discussion featuring Dr. Goldberg and Dr. Ketter. I'd like to kick off the discussion with just a few of these slides. The first one speaks to bipolar disorder and how it's often comorbid with substance use disorder and also anxiety disorder in particular, which by itself may pose a special challenge in this time period. Dr. Ketter, can you comment on this data?
Yeah, so these data are interesting. They're from the Stanley Foundation Bipolar Network study. And so Joe and I worked together in STEP BD, which is kind of analogous to this study. This particular study involved all comers, and they looked at lifetime comorbid axis 1 disorders, and as expected, found substance use and anxiety disorders were a bit higher than other comorbidities. So bipolar 1 has the highest comorbidity for alcohol abuse disorder. But in this particular study, substance use disorders were 42%, so were anxiety disorders. Clinically, we see patients that are a bit sicker, and they don't come in recovered seeking treatment, and they don't come in hypomanic seeking treatment. And so the figures that I'm more used to are about 60–70% each for these two disorders. It's interesting to see that both substance use and anxiety disorders had the same rate in this. Joe, any comments on this?
Yes, I would add these data, which are 20 years old now, are probably low estimates. Nowadays, they capture syndromes, but not subsyndromal symptoms. So if you add into this sub-threshold anxiety disorders and sub-threshold substance use disorders that may not necessarily reach the definition for DSM, it's likely even higher. And I think, we talk in the world of COVID a lot about people with underlying medical vulnerabilities to the illness. We're talking today about bipolar disorder, and these are two critically important examples of the common comorbidities that we expect to see more often than not, really, in people with bipolar disorder, and the ways in which this may make the patients we treat with bipolar disorder especially vulnerable. Anxiety, which we'll be talking a lot about, it's been said to not have anxiety in the setting of a pandemic is abnormal. There's normal anxiety that one expects to see. It's when it becomes disabling and it follows a U-shaped curve. You need enough anxiety to be able to have motivation and attention and respond to threat and process information, but too much becomes paralyzing and disabling. And so if someone comes to the picture with a predisposition for an anxiety disorder, one of the questions I often find myself discussing with patients is, where's your anxiety at? You need to have the right amount, not too much, not too little, to be able to problem solve and to get through. And someone with bipolar disorder comes with this particular vulnerability. And side by side, the risk for substance use disorders. And this is especially hard in a time of lockdown and home shuttering. And I've had my share of patients who even are not particularly identified as having alcohol or substance use disorders, who are talking about, now that the stay-at-home orders have been going on for quite some time, what do you do in the afternoon, and the sense of monotony. And so if someone has a pre-existing vulnerability to a substance use disorder, I think it's especially challenging to come to some formulation about what is appropriate use of alcohol, what is the potential for misuse with a prior history of any substance use disorder that could become reactivated in the setting of the stresses around lockdown and stay at home and coping with things. So I think these are two prime examples of the kinds of common comorbidities that make our patients especially vulnerable.
So for a spouse or a caregiver of, someone who's suffering from bipolar disorder, how would you say, what are some special guidance and advice that you can give them? Maybe they're observing that their spouse is drinking more. and maybe they're normalizing it. I mean, there's a lot of memes in social media that's going around about exhausted parents, and it's like, what's the solution for this sort of exhausted in social isolation? Wine, and it's like there's all kinds of jokes talking about how wine is sort of like the solution to in the midst of the social distancing and social isolation. So they may normalize it. They may say, everyone is drinking. I'm just drinking a little bit more. I'm not doing anything abnormal. But they have a prior history. They're suffering from bipolar disorder. What sort of advice can you give?
Well, it really depends on how their mood is when they're intoxicated. So alcohol gets used by our society generally as a mild anxiolytic, temporary anxiolytic. And if they get rebound anxiety afterwards, that's a problem. Or if they get abusive during, that's a problem. Or if they're abusing alcohol, that's a problem too. 2 drinks a day, at least in California, is not considered a huge issue.
Mm-hmm.
Joe, on the East Coast?
I think a lot of variability. I would underscore it comes back to someone's personal history, and this is where having a patient whom you've known and followed for some time makes the job a lot easier than someone you're meeting for the first time. I always tell patients, compared to your usual self, what are you noticing that's different? If someone has a vulnerability to alcohol or a substance use disorder, you look very carefully to see if that's declared itself by some point in time. If somebody is after age 40 or 50, where new cases can occur but are rarer, you'd epidemiologically think of them as being in a potentially different category than someone in younger than age 40, let's say, where their potential for a comorbid condition has yet to declare itself. So if I know Mr. Smith has bipolar disorder, I will be particularly scrutinizing of his past use of alcohol, a family history of alcohol or substance use disorders, because these things can co-segregate genetically. To Terry's point about mood, it's much harder to have a dialogue with someone about, is a substance causing a problem, if they're really euthymic. I mean, this comes up a lot with cannabis. I think a lot of patients who identify cannabis as a helpful thing, and I will often say to patients, in 25 years, I can't recall ever meeting someone with active mood symptoms who's using a substance or misusing a substance where I've been able to make many inroads in their mood as long as the substance is,
on
is
board.
active.
Yeah.
Some people who say marijuana is helpful, I say, if that's the case, then you don't need to know me. And what the work that we do is kind of like gourmet cooking, and the setting of marijuana is more like a toxic waste dump.
It's a right. If you're going to come for treatment, to me, it's the same as somebody with pulmonary disease who only smokes a few cigarettes a day or doesn't inhale. Yeah, to me, that the issue to the patient is, how far do you want to go to optimize your health? What are you willing to do? If I was a cardiologist, I would talk about lifestyle in the very same way. I can give you medications to help your cholesterol and your blood pressure and so on, but lifestyle comes into the picture. So as long as you are at risk for an event, I'd be remiss to not point out the lifestyle factors that come into play. If somebody has a risk for substance misuse by virtue of having a diagnosis of bipolar disorder, or is at risk for an anxiety comorbidity just by virtue of having bipolar disorder, as long as there are mood symptoms in the picture, which I'm assessing every time I see them, we're looking for possible causes. That can be non-adherence to medicines. It could be just the natural course of illness, but it could easily be a comorbidity such as one of these. So as we're assessing it, if your mood is fine, like Terry says, why am I seeing you? Other than to check in and make sure that things are good. But if they're not, we have to address anything that could be a contributor or a contaminant to the symptoms that we're trying to make better.
It depends if you get a clean anxiolytic effect out of the alcohol or not, without complication.
There's other ways to get to your GABA A receptor.
Right.
It actually brings up of self-medication. So rather than you know, I think if the patient, I mean, it's an excellent point. If the patient is speaking to, you know, doc, this helps take the edge off, I'm interested in whether, you know, this is a cocktail on your porch with taking your mask off and looking out, as opposed to, is there an undertreated anxiety disorder? And if there is, we have pharmacologies that can address that probably more effectively and safely.